Good evening, everyone, and welcome to this year's Clinical Radiology Public Lecture. My name is William Ramsden, and I'm the Vice President for Clinical Radiology at the Royal College of Radiologists. It's a really great pleasure to welcome you to our lecture and also to introduce our speaker, Dr. Sam Hare. Sam is a consultant chest radiologist at the Royal Free NHS Foundation Trust and recently took on a national role when he was appointed as a National Specialty Advisor for Imaging at NHS England. He represents the Royal College of Radiologists on the British Lung Foundation Task Force for Lung Health. Sam has been a very prominent chest radiologist for some time, and his lecture reflects his interest in chest radiology, which is particularly timely when the pandemic has gone through this year and continues to affect us all. The subject of his talk is Unmasking the True Face of COVID-19 through Clinical Imaging. This will be very pertinent to both radiologists and people who are interested in radiology amongst the general public. So now, without further ado, I'm going to hand over to Sam.
Good evening, everybody. My name's Dr. Sam Hare. I'm a consultant chest radiologist at the Royal Free London NHS Trust and also National Clinical Specialty Advisor for Imaging to NHS England. And I'm going to talk to you today about the role of imaging in unmasking the true face of COVID-19. It's a great privilege and pleasure to be invited by the Royal College to give you this talk today. As we all know, every story has a start, a beginning, and an end. And I'm going to try and tell you the story of the pandemic, the untold story of the pandemic, through the eyes of an imaging doctor, known as a radiologist, and the wider imaging department and community. As we all know, we have seen coronaviruses before, so we've seen SARS and MERS, but we've never seen a coronavirus that's literally changed the world and lives around us as the SARS-CoV-2 virus has. This is the virus that causes the disease COVID-19. As a starter, I'm going to explain to you what radiologists and the radiology department does. So the imaging department, I like to consider the imaging department as the hub of the hospital. And I think most patients, most of you who have been into hospital as patients or with relatives, will have some understanding of what I'm talking about in this context. So in modern medicine, most diagnosis, most patient care pathways, whether they're from accident and emergency, from surgery, from oncology, from outpatients, most patients will have an imaging test, be that an ultrasound scan, a CT scan, an X-ray or an MRI scan, as well as multiple other scans such as mammograms. All this hive of activity takes place in a radiology department. And the radiology department consists essentially of radiographers, in North America known as radiography technicians. And these are extremely valuable unsung heroes of our hospital workforce that take all the images and ensure that they are of good quality when they see patients, so that radiologists, such as myself, who are doctors, who are trained for years, 5 years or more, to study the anatomy of patients on various types of imaging, as mentioned, so that accurate diagnoses can be made on patients through their journey of their illness and treatment. So it's a vital cog in the machine of hospital medicine as well as community medicine. So many patients will come from communities to have x-rays from their general practitioners, and the image that's taken and the report that goes for that with that image provided by a radiologist such as myself will inform what happens to that patient when they see their doctor in the A&E department, the oncology department, or the surgical clinic. But radiology isn't just about imaging. So here's a colleague on the right who's an interventional radiologist, and this is a photograph that demonstrates that imaging is much more than looking at photographs of scans. Imaging is also treatment and diagnosis. So this colleague is withdrawing some fluid from a patient's chest using an X-ray to guide where he's placing this needle. In my capacity as a chest radiologist, I also treat lung cancers by doing treatments such as radiofrequency ablation, which is where we burn small lung cancers before they can grow. I have neuro-interventional colleagues who unblock arteries when patients have had strokes. So imaging is not only looking at pictures and making diagnoses, but imaging is about treatment and managing patients in addition. So this is a cartoon I came across online when I was preparing my talk, and I think this resonates with me quite a lot, and it may resonate with some patients. So when you go to an outpatient clinic, never be under any illusion other than to know that radiology and radiologists conduct the orchestra of the hospital. So this may be a physician or a surgeon who is talking to you about what your MRI scan shows, but never forget that a skilled expert radiographer has taken this high quality image, allowing a radiologist such as myself to be with you in the room. Although I'm invisible, I'm in the room with you, providing this report, which is an interpretation of this image. So this doctor can relay the information that I have provided to you and then make a judgment as to what sort of further treatment you need for your illness. So we are always there with you as a radiology community, but we may not be actually physically in the room, but we're always there with you through our reports and through our interpretation of all the images that are taken throughout hospitals. I'm going to move to chapter 1, and so it begins, the story of the pandemic. The pandemic started in around December 2019. Seems a long time ago now, and we've been through a lot as a world, as a country, as communities, and as individuals. So in a seafood market in Wuhan in China, there was an outbreak of a respiratory illness, and clusters of patients were getting ill with this new virus, which was identified and labeled in January as COVID-19. And we all know, we were watching the news, this was something that was far away, but we were seeing alarming images of healthcare workers and doctors dressed in hazmat suits treating unwell patients who had oxygen masks on. So very scary stuff, but far away. However, in February 2020, we started to see the first cases of coronavirus impacting the UK after a large outbreak in Italy, also in February 2020. And on the 11th of March 2020, the World Health Organization declared COVID-19 a global pandemic. So something that was far away in China had now arrived on our doorsteps, within our houses, within our families, and this was to be taken extremely seriously. In terms of COVID symptoms, these became familiar across the media, across the news. So COVID-19 was labeled a respiratory illness. Some of the main symptoms are a cough, a dry cough, shortness of breath and difficulty breathing. And loss of taste and smell became known later on as also a very common symptom, along with other things such as fever and occasional vomiting, diarrhea and muscle aches. Now, the reason that's important is that being a respiratory illness, the main disease caused by this virus is pneumonia. Now, what is pneumonia? So we possess 2 lungs, and within those lungs, we possess millions and millions of air sacs. And it is these air sacs which keep us alive by transferring the oxygen from the air around us into the blood within our bodies so that we can produce energy in our cells and function daily and do all the things that we often take for granted every day without even thinking about it, breathing, for example. Pneumonia is an infection of the air sacs in the lungs. So what does that actually mean? Well, essentially it means that the air sacs are full of what I just like to simply call gunk. And that gunk consists of either bacteria or viruses, inflammatory cells, white blood cells, and pus, all of which is the result of the body trying to fight the infection. And what that can lead to is difficulty breathing, chest pain, and cough. But the reason that's important, particularly for myself as a chest radiologist who spends a lot of his day work looking at imaging of patients' lungs, it means that my work and the work of all chest radiologists around the world, as well as general radiologists, changed because we started to see lots and lots of patients having x-rays and CT scans. Now, these are appearances of normal lungs. So just if I take you through this, this is an x-ray, this is a CT scan. It's very important to know that although this is on the left of the screen, this is actually the right lung, this is the right lung, this is the left lung, this is the left lung. Images are always reversed on a CT scan or x-ray as you look at them. This central structure is the heart, and this is the heart on the CT scan. Now, what as a chest radiologist, love to see is nice black lungs, because black means that the air sacs are full of air and that the lungs are healthy. Chapter 2, the surge. So this is my own personal experience as a chest radiologist, and the very first case of coronavirus that I saw where I work. And this was a male patient in his 60s who was admitted in March 2020 with fever and shortness of breath. Now, I remember looking at this x-ray and I was asked for my opinion on it by a respiratory physician. And as soon as I looked at it, my initial reaction was, oh, wow, you know, what am I looking at here? This looks very unusual to what I would usually expect to see in a standard chest infection. And I noticed that this patient has an endotracheal tube, which is an intubation tube. So he's on a ventilator. He's very unwell. And he has this white appearance in his lungs compared to the black lungs that I showed you that I usually like to see. The respiratory physician said that they had done a COVID swab test for this patient, but it had come back negative. And what did I think of this? And I immediately said, ignore the COVID test result. As a radiologist, I can tell you that this is coronavirus because this x-ray looks like the x-rays that I've been looking at in the medical journals and on the internet from the patients that are presenting to hospitals in China and Italy. So ignore the COVID-19 swab result. This is coronavirus. Isolate this patient. Institute all the isolation precautions, make sure everybody's wearing PPE in close proximity to the patient, etc. The swab test was repeated, and indeed the swab test came back positive for coronavirus. But what this shows is that it was the x-ray and the interpretation of the x-ray by a radiologist that informed the hospital that this is a coronavirus diagnosis, despite the gold standard test, the swab test, being negative. And that's very important because it shows the powerful role of imaging in determining treatment of patients. So I often get asked, what do COVID lungs actually look like? And so I'm going to show you what they look like on a CT scan. So these are normal lungs. I'm just going to let this play. And here's another example. So these are normal lungs, the nice black, and these are coronavirus lungs. And obviously the main difference in these two very explicit cases are that the lungs are full of what we call ground glass opacity in the radiology community, but essentially is a white misty appearance in the lungs. And this is what I was demonstrating before. These are the air sacs full of that gunk and mucky material that is blocking the air sacs, meaning that this patient cannot breathe as well as the patient with normal lungs and ends up on a ventilator. This is a severe illness. Usually when I see a normal bacterial infection or a normal, more usual viral pneumonia, I see perhaps a small portion of the lung that's infected. Very, very rarely do we see appearances like this where the lungs are diffusely affected like this, except maybe in patients who have compromised immune systems, so they're on immunosuppression, or they have other illnesses that make their immune systems weak. So this is highly unusual. And in the surge of the coronavirus pandemic, what I often have said is that metaphorically, as radiologists, as healthcare workers in the hospital, we metaphorically ourselves couldn't breathe because we were just seeing case after case after case of patients looking like this. Ordinarily, I might see 1 or 2 chest x-rays showing a pneumonia in my usual workload in the day. Whereas I can honestly say that during the surge of the pandemic, I was seeing 40 to 50 cases of patients with X-rays and CT scans looking like this, because our hospital just became flooded and full of coronavirus patients, to the point where we ran out of beds, we ran out of accident and emergency space. So it was a very difficult time and a little bit chaotic, because ultimately we were dealing with a new disease and we had to really reset and think about how we would deliver our service in that context. So the usual test done for coronavirus is a PCR swab test. Now, but this has its challenges, and one of the main challenges for this test, which is performed by putting a swab into the throat and the nose, is that it can take often more than 24 hours, sometimes 48 hours, to get a result back. We know that China, when the virus first started, ran out of PCR testing kits, and we also know that up to 20 to 30%, so almost 1 in 3 cases, can be falsely negative. So a result that comes back as not showing coronavirus, but the patient actually has coronavirus. And then having to retest those patients obviously adds on further delays. Now, that's really critical in a hospital full of coronavirus patients, where you need to make instant decisions about can that patient go home? Does that patient need to go to an open ward? Does that patient need to go to an isolated COVID ward? So waiting 24 to 48 hours is not really ideal for determining an infection control strategy that then affects our communities if we let patients leave the hospital and go back home, if they've tested negative on a PCR, or do we wait 48 hours? However, what is the test that can give you an almost instant answer? And that's the chest X-ray or the CT scan. So there became a heavy reliance on using X-rays for immediate hospital diagnosis of coronavirus infection, while we were awaiting the results of the swab test, which is more definitive. Now, what's the context of that? So here's some of the graphs that we were seeing on the daily briefings from the government, with lots of regional differences in coronavirus and the initial surge here. The context of that is there's a huge national shortage of radiologists. So the demand for imaging investigations is going up like this, but the supply of radiologists isn't going up nearly as fast. So we have this huge shortfall. So if you then think about this in real terms, we have a global pandemic. We're relying on X-ray, rapid X-ray reporting, rapid CT reporting, with not many radiologists to determine our infection control strategy within hospitals. So you can start to see just how resources were constrained and how difficult things were. But the NHS, as we know, always has the ability to be malleable and find a way through a crisis. And partly that was because of Chapter 3, imaging took center stage on the COVID frontline. And this is the heart of the untold story of the coronavirus pandemic. Life changed. So radiographers, the very people who do such a vital job in taking all of those images, taking all of those CT scans that a doctor like me, an imaging doctor, can interpret, had to perform these tests wearing either gloves and aprons for low-risk patients, but full PPE, personal protective equipment, for high-risk patients. I myself was performing procedures and treating lung cancers and biopsying lung cancers wearing personal protective equipment to do biopsies, and that's very difficult. It's very difficult to see through a mask when your glasses fog up, when you're breathing and you're wearing a mask, and it's difficult to breathe. But that was life during the pandemic. We all had to find different ways of working, but still deliver great care to our imaging patients. Here's some images of COVID on the front line. So here's some of our amazing radiographers getting ready to CT scan patients. And this became the norm in multiple hospitals, where we had radiographers dressed in full personal protective equipment, taking their mobile X-ray machines and going to the very heart of the sickest patients in the intensive care units and the accident and emergency departments. So usually the patient would come to us to have their X-ray in the department, but to try and limit the spread of infection, obviously radiographers were going and taking their machines to the patients and then cleaning the machines appropriately afterwards to ensure that there was limited spread of infection in the hospital. So this was happening, and as you know, most patients who came into the hospital, nearly every single patient would have an X-ray to help tell us how bad their coronavirus infection was. Every single patient was having an imaging test for their coronavirus if they were coming to hospital. And that often is the untold story of the pandemic, as I've said. This oil that was driving the machinery of the hospital was the imaging department. One of the main questions we had to answer was, should we be CT scanning all patients or not? And most of our information from this was, in the early days, taken from the study that was performed on the Diamond cruise ship that we would have all seen on the BBC News. So this was a cluster of cases outside of China, off the coast of Yokohama Bay in Japan, where amongst the cruise ship holiday makers, a number of them, around 100, caught the virus. What this told us was that, firstly, up to 70% of those patients had no symptoms whatsoever, but they tested positive for coronavirus. But what it also told us was, in those asymptomatic patients, some had abnormal CT scans, so the white misty lungs appearance, and yet nearly half of them had completely normal CT scans. This is why CT in coronavirus is a bit of a minefield and a difficult judgment to make, because a CT scan can be entirely normal and show nice black lungs in certain patients who have coronavirus, particularly early on in the coronavirus infection. And therefore, the normal standard X-ray became the main tool to triage the severity of patients' illnesses. And as a chest radiologist, I can say that was more than good enough. The chest X-ray became the key diagnostic tool for patients and managing infection control strategy while we were awaiting the results of the formal swab tests. The chest radiology community also came together to produce national guidance so that there was less unwanted variation around the country. So essentially what this meant was that every patient having a chest X-ray and every patient having a CT scan for coronavirus was reported in the same way. And that's very, very important, because when we do our reports as radiologists, we often have artistic license to make our interpretation, which should be allowed because different radiologists interpret images differently. But in a global pandemic where you want to make sure that every patient is getting the same diagnosis, where you want to make sure that you collect data in a consistent manner so you can learn more about the virus, it's more vital than ever to make sure that everything is reported by every hospital, from your smallest hospital to your largest hospital, in the same way. And this guidance was produced by chest radiologists from the British Society of Thoracic Imaging, of which I am a member, to provide that guidance and to provide that organization amidst the chaos in how we interpret our images. And essentially what we were left with were 4 categories of chest X-ray reports. Normal, so a normal chest X-ray, but the so-called classic COVID chest X-ray, which is this white misty appearance at the edge of the lungs. There's another example of this white misty appearance on the edge of the lungs in another coronavirus patient. This is where a chest radiologist earns his corn. So this chest X-ray looks almost normal, but actually with a detailed look, which is what chest radiologists and radiologists do every day, we can be the arbiter of whether a patient may have coronavirus or not. Because if you look very carefully, this patient has some asymmetric shadowing, which may be quite difficult to see, but definitely has some asymmetric shadowing in the left lung, and this patient also had coronavirus. This would be called an indeterminate chest X-ray. And this is a non-COVID chest X-ray, and it was important to label non-COVID X-rays non-COVID rather than normal, because this patient's got a large lung cancer sitting behind the heart, which is this mass that you can see here. So this systematic reporting of X-rays as classic, indeterminate, non-COVID or normal was rolled out throughout the whole country, and every patient was getting the same report, and that allowed us to cascade infection control strategy across the NHS, and that was led by the imaging community. We also set up, as a chest radiology community, a huge anonymized digital imaging database, so that the anonymized X-rays and CT scans of COVID patients could be shared. Now, if you think about it, we're dealing with a new disease, a global pandemic. It's really important that doctors across the NHS talk to each other and share their learning so that you can provide faster patient assessment and save lives, because you're learning about the disease as you go. And it was crucial that, for example, hospitals in Leeds were sharing their images with hospitals in London, so that different regions who were having more or less cases could be ahead of the game and know what to expect. So this was vital. And radiology and imaging, because everything is now done on a digital platform, so that when an X-ray or a CT scan is taken by a radiographer and passed to a radiologist such as me to report, gone are the days where we look at a film and hold it next to an X-ray box. Everything is now done digitally on a monitor and a screen through a computer, and this enables us to share our learning much better across the national platform. Some of the other lessons we learned in radiology was that we changed our working patterns to segregate our areas and scanners into, those of us that are lucky to have 2 scanners in our hospitals. One scanner would be only for non-COVID illnesses, and the other scanner would be for patients who were who we suspected had coronavirus infection or had definite coronavirus infection. And that was vital to keep patients separated and to reduce the risk of contaminating patients who didn't have the virus with the virus. That also extended to having dedicated clean hospital sites and COVID hospital sites. So you will have heard that the NHS procured the private independent sector, which doesn't usually have accident and emergency departments, to perform non-coronavirus scans for cancer, scans for kidney stones, scans for heart disease, and that the COVID sites, the places with the accident and emergencies, were doing all the COVID scanning. And that was vital, because in modern medicine, only if you get your imaging test can you achieve early diagnosis and start early treatment. So one of the problems in the early days of the pandemic and coronavirus was we were unable to scan our usual elective cases, or even sometimes our cancer patients. So very, very quickly, we had to develop a strategy which enabled us to carry on providing X-rays and images and MRI scans to people who didn't have COVID, because if all that shuts down, you're left with a huge problem with patients getting delayed treatments for cancer, etc. And so these strategies were put in place to limit the damage from that. We also started reporting chest X-rays through the night instantly as they were done. So I remember doing overnight on calls, staying awake, and as soon as patients' X-rays were done, I would report them as either classic, indeterminate, or normal or non-COVID, so that the A&E department and the doctors seeing these patients physically and treating them would have an instant X-ray report, so that they could know whether or not this patient could be sent home. Would they need to go to a COVID ward, or would they need to be separated in a non-COVID clean ward? Now, what about lung cancer? Very important. It's very important to remember that some of the symptoms of coronavirus, cough, shortness of breath, are very similar to some of the symptoms that you can see in lung cancer. So we had to develop pathways and systems and media campaigns to make sure that patients who had fever and cough but were being told to self-isolate at home, if that fever and cough had been going on for a long time, months, it was vital that those patients still came forward to have X-rays and CT scans to make sure they didn't have lung cancer. It's very important to sort of not have mixed messages. On the one hand, telling patients to self-isolate at home if they have a cough, but on the other hand, if they have had a cough for a long time, to come forward to hospital to make sure they don't have lung cancer. It's a very, very difficult time, and we developed systems and we communicated with our local general practitioners and NHS England to sort of develop a strategy to make sure that that was still happening. We hoped that antibody testing would help us open up our system. My own personal story is that I myself tested positive for coronavirus, but months later I had an antibody test, but I tested antibody negative. So there are a number of patients out there who've had the virus who may not even have any antibodies, and a number of healthcare workers who are in the same position. And so this didn't really open up the system to this day as we expected, but it does have some use. And the other thing that happened was that rapid PCR testing became available. Although the supply was limited, we did have a certain number of tests where we could perform. If as a radiologist I suspected that a patient had a high risk of having coronavirus but needed an operation for their appendix, and we needed to keep the surgeon safe from catching coronavirus during the infection, some of those patients would be getting a rapid swab test, which would come back in 45 minutes to be able to tell us whether or not they really had coronavirus or not. So that started to open up the system a little bit. But this is a new disease, and there were many, many challenges still faced. So I remember this patient distinctly well, a 30-year-old patient who presented with a tummy ache, abdominal pain and a fever, and the surgeon came to me and said, can you scan this patient's tummy, please, because she doesn't have any coronavirus symptoms. I'm worried that she's got an appendicitis. I sort of thought about this, and I said to the surgeon, look, some patients can present with abdominal pain. Let's just get an x-ray of this patient when they're on the CT scanner, and this shows some white spots that I can see as a radiologist. And we did the CT scan, and it didn't show any evidence of appendicitis, but the lungs showed these spots in the lung which were consistent with coronavirus infection. So this patient actually had coronavirus without having any shortness of breath and only abdominal pain. So patients with abdominal pain, diarrhea, tummy ache can have coronavirus, and that's really important to recognize, and we learned that during the initial part of the pandemic. We were seeing patients with unusual clots in their blood vessels. So this is a pulmonary artery, and this black snake-like structure is a blood clot in that vessel. And this is a patient's abdomen, tummy, and this black snake-like structure is a blood clot in the abdomen. And so we then started to discover that coronavirus isn't just a respiratory illness in the sense that it causes this white misty appearance in the lungs. It also causes patients to develop blood clots, and that can be in the lungs, it can be in the brain and cause strokes, it can be in the tummy. And so we navigated our way through that, and then chapter 4, lockdown. Lockdown happened, and the attempt of lockdown was to protect the NHS, protect lungs, and stop the community transmission of the virus, to take the pressure of off the NHS so we could do our jobs, find some order amongst the chaos, develop these systems so that we could then come through the other side, flatten the curve, as happened during lockdown. So this is the daily death charts that we were seeing on the government briefings. We started to flatten the curve and take the pressure off the NHS, including the imaging community, to try and open up our routine operations and other treatments, and to try and get some order into the system. And that was very successful. However, chapter 6, the road is still long, and it's really important to recognize that. So some patients with coronavirus infection I saw, and chest radiologists around the country saw, were still inpatients more than 4 to 6 weeks after their infection if they had a severe case of coronavirus. Here's a patient with diffuse persistent white mist in their lungs who's developed this large black circular mass in their lungs, and this is a localized lung collapse. So we were seeing things like lung collapses in patients. As I said, we were seeing blood clots in patients, and we started to see the early signs of lung scarring in some patients. As we all know, long COVID became talked about in the media. Patients more than 3 to 4 weeks after their infection, even once they've left hospital, even patients in the community who never presented to hospital but tested positive, still demonstrating fatigue, shortness of breath, and multiple other symptoms. And interestingly, in the last week or so, a study came out of Italy, which was in the newspapers, that demonstrated that in post-mortem patients who had died from coronavirus, they discovered that those patients' lungs had established lung scarring, something we in the radiology community call fibrosis, which leaves permanent damage to your lungs as a result of coronavirus. Now, we know from SARS and MERS, the old coronavirus infections, that this can happen. But obviously the worry is so many people have been infected with coronavirus that even if it's a similar proportion of patients that get lung scarring compared to the other coronaviruses, say 20%, 20% of a huge number is a far greater resource problem for the NHS than 20% of a smaller number of patients has happened with the other coronavirus. People often ask me what actually is lung scarring, so I'm just going to give you a demonstration of that from a BBC video I did for the BBC News, which is available on the internet. So I'm just going to play that for you.
I'll give you an analogy with a plastic cup. So if you consider, Sophie, that this is an air sac in the lung, we have 300 million of these, they're full of oxygen. coronavirus will fill this glass and make it incredibly difficult to breathe, much like fluid filling the glass. You may end up on a ventilator as a result of that. Now, scarring will potentially happen at 6 to 12 weeks after your infection, and essentially what happens is that the air sacs will get distorted, destroyed like this, meaning that you cannot consistently breathe as you were before you had the virus.
So this is a case in point. So hopefully that visual demonstration gives you some idea of why patients may have persistent shortness of breath after getting coronavirus. So this is the patient that I saw, my very first patient that I mentioned, with this peripheral misty appearance. But 6 weeks later, on day 42, you can see that the lungs haven't quite returned to normal. They're not that nice, overtly black appearance that you want to see. Yes, the patient's off a ventilator because the intubation tube has been removed, but there is a permanent scarring of this lung 6 weeks after the infection. And that's why it's so important during lockdown, which we've entered currently, another lockdown, to stay at home, protect people's lungs and reduce transmission of the virus. It's a vital message. Chapter 7, are we going to have a second wave? Well, some people would say we're in the midst of a wave, but will there be a true second wave? Now, 3 scenarios have been suggested. One is that we may get consistent peaks and valleys of coronavirus that come and go. The other is that we have a second peak that's bigger than the first peak. And the third scenario is that this is the first peak, that we have a slow burn in the background of patients presenting to hospital with the virus. Interestingly, in the 1918 Spanish flu pandemic, we saw scenario 2, where the second peak was actually more severe with more patients than the first peak. So we need to be prepared for something like that and be vigilant. Where are we now? Well, we're in a state where the death rates have been rising up to November, and the amount of patients in hospital has been rising, although the amount of patients on a ventilator, although rising slowly, is nowhere near as high as the amount of patients in hospital. We're in a lockdown as a result of this curve starting to spike, and they're threatening to be a true second wave. It's really important to remember that when you get symptoms from coronavirus from your infection, it may be 9 to 19 days before you feel unwell enough to present to hospital, that this infection does hang around in your body for a long time, and that it was important to lock down when we did, because that was 2 weeks prior to any perceived huge increase in rises of cases. And we can see at the start of October, thanks to NHS England, and the end of October, that the purple representing more severe cases of regions with more severe and more numbers of coronavirus, that the purple on this UK map, and this is London, is getting more and more purple, particularly in the north of England. So no option, we have to lock down, we have to reduce community transmission of the virus and stop, prevent patients presenting to hospital, and take the pressure of the NHS as winter is approaching, which is always a difficult time in usual circumstances. We know that it's the elderly population that tends to get hospitalized, so those over the ages of 75, particularly those over 85, really important to protect those that are more vulnerable from being admitted to hospital. Chapter 8, the future. Well, what does the future hold for us? Well, we must remember to remain patient, and that this is an evolving story. It's been a roller coaster through the initial surge, the chaos of the surge, restoring some order to the surge. Only last week, I saw in the media and read some articles of a mutation in the virus that has occurred in minks and has been demonstrated to be potentially transmissible to humans in Denmark. Where does that leave our vaccine? Is our vaccine going to be effective? But only today and yesterday, this week, we've heard of much more hope that there possibly is a vaccine that is 90% effective against coronavirus, possibly offering us some hope at the end of this long tunnel. But what I would say is, at the moment, it's important to be vigilant and stay patient. There may be some hope, but it's important to keep protecting lungs by staying at home, reducing community transmission, focusing on washing your hands, wearing face coverings and masks, and being socially distanced. Lastly, I just wanted to say that the NHS is here. We're open for you. Help us to help you. Do not self-isolate or shield at home if you've got worrisome symptoms such as blood in your urine, or when you go to the toilet, or whether you feel a breast lump. If you feel unwell, help us to help you. Come forward, present to the NHS. As I've said, we've put an infrastructure in place where we have clean, non-COVID sites, COVID sites. You can be rest assured that you'll be safe when you present to hospital. It's vital that we look after non-COVID illness, the cancers, the heart attacks, the kidney stones, the appendicitis. It's vital that you present to hospital and have your imaging test so that we can diagnose whether or not you have any of these other conditions and not only think about coronavirus. So help us help you. Thank you very much. I'll just leave you with these last messages and we can take any questions that there may be. Thank you very much.
Thank you, Sam. That was a fantastic talk. So interesting to hear about your experiences as a chest radiologist, but also in the greater context of the NHS and how things are changing going forwards. I'd like to start the questions off, and then we'll take questions from the audience, if that's okay. If you can hear me okay, may I ask you, when you look at the imaging, when the patient first presents, when you look at that chest X-ray or that CT, does how bad it looks give a prognosis? Do the bad chest X-rays and bad CTs turn into people who stay in hospital a long time, or is it not quite like that?
Generally, so hopefully you can hear me. So there's a lot of the patients who tend to come to hospital with symptoms are usually those with the more severe X-rays by definition, because those with more mild symptoms are shielding at home. But what we are seeing is that the younger people who have their lungs affected in a bad way do tend to bounce back and do better, and maybe don't end up on a ventilator, but are fine just on the oxygen. But the older patients do tend to end up on a ventilator. But we're seeing something different now in this second wave or continuation of the first wave, however we want to look at it. And the difference is, because steroid treatment, particularly dexamethasone, has now been proved in the NHS to be effective in treating coronavirus patients, we're seeing far less patients ending up on ventilators because they're getting the steroid treatment when they present, and so perhaps the course of their illness is shorter, and they're not ending up on ventilators requiring some oxygen and going home. So that's been a definite main change in patients this time around.
Thank you very much, Sam. I'm going to go to some of the audience questions now, if that's okay. The first one is there any long-term impact of SARS on the lung?
Yes, so SARS a few years ago now, but there was similar. We saw, the first thing to say is we saw far less patients, but there were patients on ventilators, and those patients with prolonged SARS pneumonia did also develop lung scarring, what we call fibrosis, particularly if they'd been on ventilators for a long time. And that's where we're getting our information a little bit on coronavirus, COVID-19. So although we're dealing with a coronavirus, and the impact on the lungs is sort of similar to what SARS was doing, but is worse. So I saw a lot of SARS cases. The lungs were affected, but not so diffusely and widespread as they are in COVID-19, although we did see some patients like that, but they were the minority. But in the minority, they did develop lung fibrosis or scarring in up to about 20 to 30% of cases. The reason we're sort of worried about it with this virus is, as I said in the lecture, even if there's 20 to 30% of cases that end up with potential lung scarring, 20 to 30% of 500,000 people is a far bigger number and a far bigger resource burden on the NHS than 20 to 30% of 10,000 patients. But yes, we did see similar appearances from SARS as well.
Thanks, Sam. There's another question here about long COVID. The questioner has asked why people with long COVID have continuing issues with their lungs when their X-rays and CT scans might look clear or not too bad. Is that a situation you've encountered?
Yeah, it is a situation we've encountered, and strangely, what we're seeing anecdotally, we're still doing research on this, is those patients that tended to have a more milder illness and perhaps only had mild shortness of breath. There's a group of them, a significant proportion, who tend to feel unwell for a longer period of time, whereas some people who had quite a severe illness, particularly the younger people, have bounced back and almost gone back to normal. And partly it's because when you're shielding, when you're unwell, or when you're run down and fatigued, you do become deconditioned. We've got to factor in the fact that we've had a lockdown, gyms have been closed, we haven't been exercising, and that deconditioning also affects your breathing. But there's just so much we just don't know about the virus. And I myself felt, just not quite right for weeks and weeks, but only had a very mild illness and had a normal X-ray. And this is partly we just don't know why. But what we do know from the recent Italian study is that a significant portion of patients do get significant lung scarring, and as a result of that, a lot of hospitals, mine included, are having what we call post-COVID huddles or post-COVID meetings to specifically follow up those patients. And what we're finding is the lungs take a long time to recover in those cases, and that's unusual for a chest infection. So usual chest infections have cleared by 6 weeks at the latest, whereas we're seeing patients 6 months on with still some mild lung damage, which maybe when they're sitting down and watching TV, they don't feel short of breath, but they do feel it when they're doing mild activity, like going for a walk. It's just so much is unknown, it's speculation, but one thing we can say is that we are learning lots more about it, and now that the second wave is potentially here, we know a hell of a lot more than we did during the first wave about how we manage these patients, how rehab is important, how chest physiotherapy is going to be important to get people back on their feet.
Thank you, Sam. There's another related question on long COVID. The questioner has said that many patients with long COVID didn't have any imaging initially, but are having scans now because they're getting respiratory problems. What sort of changes do you see on the scans in patients who have long COVID now?
So there's different categories of long COVID. People have talked about there being 4 syndromes. One might just be fatigue, but I'm going to talk about the subset of patients that do have lung scarring or some permanent damage. And what you see effectively is not the black lungs that I've showed you that are normal. You also don't see that white mist, but what you see is, how can I describe it? Like little streaks, white wispy streaks, which look more like lines. But what you're seeing is that the lung is, as I showed you in the demonstration with the cup, the lung is distorted and squashed in those areas. And effectively what that means is in those areas of the lung, there is far less effective oxygen transfer into your blood. And it's oxygen transfer into your blood that gives you your energy to do activities, like walking, exercise, normal things that we do every day. And if you can see why, if in those creased areas of lung, if you have less oxygen exchange, you are going to be tired for a particularly long time. Now, the concerning thing is, by its very definition, lung scarring or lung fibrosis, as we call it in the radiology community, it's irreversible. So you will have that for the rest of your life, but maybe you can adapt and the rest of the lung might be able to compensate for you. And I think that this time around, let's fast forward 6 months, my gut feel is we will see far less patients with that creased, squashed appearance of the lung because we're giving steroids. And the main reason we give steroids is it reduces the organization of the pneumonia that you get in your lung, and that's the thing that leads to scarring. So I'm hoping that with this dexamethasone drug, we will see far less of that second time around.
Thank you very much, Sam. The next question is what is the difference between an MRI and CT for finding COVID?
So CT scan is effectively using radiation, using X-rays to look at the definition of the lungs. And MRI doesn't use radiation, but it uses magnets to give you information about the lung. In simple terms, MRI is not that great at looking at the air sacs of the lungs. It can be quite good for looking at blood vessels in the lungs, but with COVID being a pneumonia and primarily looking at the air sacs of the lungs, it just doesn't give you the resolution or the definition of the actual architecture of the lung to give you any information about lung scarring. And an MRI scan of the lungs basically looks like looking at the lungs like through some fog. It's blurry, it's very dependent on movement, and you don't quite see the lungs very clearly. But a CT scan, when you hold your breath, you can see pristine appearances of the lungs. So MRI isn't really used for looking at the lungs in that way.
Thanks very much, Sam. There's another long COVID question here. A questioner who has had long COVID themselves and saying, it feels like having rheumatoid arthritis, but especially severe bone pain and small fractures, which seem to happen very easily in fingers and toes. Can this be detected with radiology? And if so, how?
So it's that area of the unknown. So people talk about different syndromes of long COVID. So yes, so if our rheumatoid arthritis patients get lots of imaging, and they have imaging of their bones. That MRI is good for looking at bones, for example, and we also use X-rays to look for fractures in hands and joint problems. Now, quite pertinently here, so we can talk about that difference here. So an X-ray can look for a fracture, but an MRI can look for more subtle things like the earliest sign of a fracture or some infection in the joints and things like that. So yes, radiology, for example, if this person who's asked the question presented to their doctor with the symptoms of joint pains, I have no doubt that you'd be referred for various radiology investigations. Yes, you'd be referred for blood tests. Yes, you'd have a clinical examination. But until you've had your radiology, which is actually how I like to say, giving the patient and the clinician and the radiologist sight beyond sight. So imaging gives you sight beyond sight. It allows you to look deeper at your anatomy and predict why you're getting those bone and joint pains. And yeah, definitely, radiology would be able to help you on your journey and find out why you've got those symptoms.
Thank you, Sam. Another question about the non-chest side of COVID. The questioner has picked up on your talking about COVID presenting as abdominal pain. And what they ask is, are there any scans that can show the virus infiltrating abdominal organs, such as the appendix or intestines?
So what we've seen is that although patients present with abdominal pain or tummy ache, the illness is almost mimicking an appendix infection or a gallbladder infection, but none of the patients have those features. The gallbladder and the appendix always look normal in COVID patients generally, and it is the lungs that are somehow causing those symptoms. Why that happens, we don't know. But yes, of course, so doing the imaging test, one of the reasons for doing that imaging test is to make sure that the appendix is normal and the gallbladder is normal, and to try and see why the patient has abdominal pain. But I haven't seen a case, apart from that case I showed you of that blood clot in the abdominal vessel, where I've seen actual infection or virus infiltrating the appendix or the gallbladder. It tends to be clots in blood vessels, and maybe I think part of the reason that patients might be getting those types of symptoms is maybe they have micro clots in the blood vessels in their abdomen that is mimicking those types of symptoms that you wouldn't see to that level of detail on a CT scan. But what the CT scan or the imaging is used for is, to make sure the patient doesn't have a kidney stone, a gallbladder infection, a gallbladder stone, or an appendicitis.
Thank you very much, Sam. Someone's come with a more general question here, asking, can radiology detect reduced bone density?
Yeah, so you'll have something called DEX. Radiology can basically detect almost anything if you do the right test, is what I say. But radiology can also give the reassurance that things are normal, because it allows you to look beyond the skin inside your body. Radiology is used very commonly to quantify bone density and diagnose osteoporosis, and even further we use MRI to see if people fracture parts of their vertebral bodies or spine because of their osteoporosis, to see do they need any interventional radiology, such as injecting substances into those bones to expand them a bit and stuff. So radiology can definitely detect reduced bone density, but radiology can also be used to treat reduced bone density if you have a fracture of one of your vertebrae, for example. So radiology isn't just about imaging, as I said, it's also about treatment on occasion.
Thank you, Sam. Thank you for taking that very general question. There's a slightly more specific one about long COVID again. There's been a lot of talk about mast cell activation syndrome recently. Are there any scans that would show this, or is it at a cellular level?
No, so mast cell activation is at a cellular level, but you can have the secondary response because of mast cell activation. So, for example, you might have a huge, what we call cytokine storm, or a huge, almost like an allergic reaction. And sometimes you can have the secondary manifestations of that in the lungs, for example, or in the airways and stuff. But you wouldn't, I don't think you'd be able to say that this appearance is due to mast cell activation. That would be in combination with blood tests and some cellular sort of detail. It can give you a hint of it, but you wouldn't diagnose mast cell activation on imaging alone, no.
Another long COVID question, Sam. Many long COVID sufferers have abnormal blood results of thyroid, pituitary and other glands, especially cortisol, causing symptoms like Cushing's. Can radiology look at malfunction of the endocrine glands?
Yes, so we often get endocrinology requests precisely to look at things like the adrenal glands, which produce cortisol, the pituitary gland, which can also develop tumors, but also produces obviously hormones that control the rest of the hormone system, and very commonly the thyroid gland. So imaging, let's just take the thyroid as an example, is an excellent test for the thyroid gland. Ultrasound, which doesn't use any radiation, similar to the ultrasound scans that you do during pregnancy, for example, can get really good detail of the thyroid gland. You can even do color scanning of the thyroid gland, which can tell you what the blood flow is like in the thyroid gland and help you distinguish between somebody who might have an overactive thyroid or an underactive thyroid, detecting thyroid cancers. And then you can do functional scans where you can inject various substances labeled with iodine, which tends to collect in the thyroid gland to try and determine if you do have let's say, a spot in your thyroid gland, is it hormonally active or is it inactive? So yes, you can have anatomical imaging, which tells you about the structures of things, but you can also have functional imaging, which tells you about how much blood supply tumors and things of the thyroid gland have, or how much hormones they're producing. So definitely you can look at the endocrine system in quite a lot of detail with imaging.
Thank you very much, Sam. We're going back to the lungs now. And the question here, is SARS a predisposing factor for lung cancer?
Is SARS a predisposing factor for lung cancer? No, not really. However, some studies have shown that lung scarring or fibrosis in the lungs can sometimes, very rarely, be a risk factor for developing lung cancer. However, that's usually in the context of a specific condition called idiopathic pulmonary fibrosis, which is basically lung scarring where we don't know what's causing it. And it's a condition that we're doing a lot of research around. It's been around for a while, but there wouldn't be any direct link between SARS and I think it is important to rate is if you've been shielding at home, but you've had a cough for a long time, you feel breathless and you've been shielding or thinking that it's long COVID that you've had for months and you haven't originally presented to hospital and have had no diagnosis or no swab test for your COVID, don't assume it's long COVID. Come forward and be tested for lung cancer, because some of the symptoms, such as an ongoing long-standing cough or feeling short of breath, those symptoms are also partly symptoms of lung cancer, including other worrying signs like weight loss. But if you do have those symptoms, don't automatically assume it's long COVID, particularly if you haven't had a COVID test. Do come forward, get your X-ray, get your investigation, and make us and help us to help you in diagnosing whether or not you do have lung cancer and give you that reassurance.
Thank you very much, Sam. Another question from the long COVID perspective. The questioner took part in a study to look at organ damage in long COVID. It found problems with the mitral valve of my heart, small lesions on my liver, and a tumor on my liver. And the questioner wants to know, are these temporary or permanent?
Well, I wouldn't know. I'd have to look at the imaging. So we can have benign tumors, we can have malignant tumors, and just a verbal question like that, I wouldn't be able to. It would be remiss of me to make any speculation on what that is. You can have benign tumors that self-resolve, and obviously you can have malignant tumors. But what I would need to do is look at the imaging in great detail, what type of imaging that was. The heart, obviously. There are reports that the heart can be affected by coronavirus, but that tends to be an inflammation of the muscle of the heart rather than the things that were described in that question. But I just simply wouldn't be able to say whether or not that was permanent or not without actually looking at the imaging investigation.
I think that's true, Sam. I think it's quite difficult to give individual health advice from your perspective as our speaker, though it's very interesting to hear people raise all these issues. It looks like we've reached the end of the questions. Yeah. One more has come in, about neurological symptoms in COVID, Sam. Also mental health issues. Can radiologists look at brain and nerve damage in COVID?
Yeah, we have been doing some MRI scans for the brain in COVID. So MRI imaging is excellent for looking at anatomy of the brain and looking for very small abnormalities in the brain. And there are reports of, as I said, blood clots. They're looking for micro small strokes from COVID, looking for things like meningitis, etc. So we're very, very good for looking at that. And in terms of mental health in general, obviously it's been a difficult time for everyone. Lockdown, has impacted mental health. But where imaging would come in here wouldn't be so much to diagnose the cause of the mental health, but imaging is often used in that setting to make sure there is no what we call an organic cause for that mental health, i.e. there isn't a tumor or something in the brain that might be causing some of these symptoms. So in that sense, it's used to rule out other causes, but definitely for looking at the impact of COVID-19 on the brain, which can affect blood vessels, as I said, imaging could be used and has been used in the form of MRI scanning.
Thank you very much, Sam. I think now we should wind it down, and I would really like to thank you on behalf of the college for such a fantastic lecture, and I hope on behalf of the audience too. I also think you've answered the questions in an amazing and exemplary fashion. I mean, to show such knowledge of so much is a real credit to you. So can I thank you on behalf of everyone, and hope that everyone who attended the lecture enjoyed the evening and Sam's responses. We will give you a virtual round of applause, Sam. Well done.
Oh, thanks for having me. Thank you for listening.
Okay, and with that, we'll wind it up and say goodbye to everyone who's tuned in, and enjoy your evening. Bye.
Bye-bye.